today we have with us Dr. Ryan Metcalf from University of Utah, and we're going to discuss the 2025 AABB and ICTMG clinical practice guidelines for platelets.
So I know ICTMG is the International Collaboration for Transfusion Medicine guidelines.
Yes, and AABB is the Association for Advancement of Blood and Biotherapies.
Fresh and hot off the press, just recently released.
Just published in JAMA. I'm so excited about this. And Dr. Metcalf certainly has expertise in this topic. His titles include Section Chief of Transfusion Medicine at University of Utah, Associate Professor of Pathology, Medical Director of Patient Blood Management, and he's the Chair of the Clinical Transfusion Medicine Committee at AABB. Thanks so much for joining us today, Dr. Metcalf.
Thank you, Marianne and Sarah. It's so good to see you both.
If you wouldn't mind, would you first give us a quick overview of what role do platelets have in our bodies and how donor platelets are used in medical practice today?
Absolutely. So platelets are a type of blood cell that are made in the bone marrow by a cell called a megakaryocyte. And what buds off into the blood circulation are platelets from those megakaryocytes. And they're relatively small cells. They actually don't have a nucleus, and they play an important role in hemostasis. So helping the formation of a clot in terms of physiology, and also they play a role in vascular integrity and have some immune roles as well. But in general, we think about them as having effects on hemostasis, and a typical quantity of platelets in the bloodstream or platelet count would be reference range between 150,000 and 400,000 platelets per microliter. So there's a lot of platelets circulating through one's blood. And conditions where platelets are decreased, especially if they're severely decreased, that's when clinicians may consider, in some circumstances, depending on the risk-benefit calculus, whether platelet transfusion is indicated. The rationale is that if we increase the platelet count in somebody with a very low platelet count, that from platelet transfusion, that it could either prevent or be used to reduce bleeding. So that's the typical rationale for why platelet transfusion is given.
Okay. What was the need for new platelet guidelines?
About 10 years ago, the AABB and the ICTMG released platelet transfusion guidelines. They were separate documents. Since that time, you can imagine 10 years have gone by. There have been newer studies that have also been published. And so it made sense to evaluate the literature and try to make updated recommendations based on the best available evidence. And before all of that, we got together and talked as organizations and thought it would be a good idea, rather than doing separate efforts, but to work together collaboratively for hopefully a go-to product that's useful for clinicians making the decision to transfuse platelets in various clinical circumstances. So that's what we did.
So who made up this expert panel?
The panel is actually quite large. I think we have 42 authors on the byline of the paper. So this panel consists of many different types of experts, people from AABB's Clinical Transfusion Medicine Committee, which I'm involved with as chair, people who've been involved with prior guidelines with the AABB. So a lot of expertise there. ICTMG, their leadership, and folks who've been involved with platelet guideline development as well. And then it was important for us to include clinician experts from various specialties that might transfuse platelets. So hematology, oncology, we have interventional radiology, neurosurgery, cardiovascular surgery, so a variety of different clinicians. And then it's really important to use good methods when you're developing clinical practice guidelines that are hopefully trustworthy. So we had methodologists to help us with that.
Nice.
We were very fortunate to have a methodologist who actually was the lead author on the development of grade methodology, Dr. Gordon Guyetz. We're very fortunate there. And patient partners, we wanted to get input from patients who've experienced transfusion in the past to kind of keep us grounded and make sure that any recommendations that we make as a panel include consideration of their values and preferences and the perspective of the individual patient. So that was all sort of part of the process. And I also want to mention on the steering committee, It certainly wasn't just me. Simon Stanworth from Oxford was on the steering committee, Susan Nahirniak from Alberta, and Brenda Grossman from Washington University. So the four of us comprised the core steering committee.
Oh, that's
Wow.
amazing. That sounds like a really great, diverse population of input there. So that's awesome. And the patients too. So exciting.
Oh, I should highlight that because these are international guidelines, I should have mentioned also when we're talking about the panel, we had people on the panel from many different countries represented as well.
Right.
That's something that we certainly had folks from the U.S. and some other countries, but we tried to be as diverse as we could worldwide.
That's fantastic. Tell us a little bit about the structure in the study.
So the overall process, as I mentioned, we follow something called grade methodology, which is an established approach to putting together all the evidence related to platelet transfusion in this case, and just trying to get an idea of what the impact of platelet transfusion is on important patient outcomes. Kind of what I mentioned earlier, but probably bears repeating as well. We have to decide what our values and preferences are, what are the most important patient outcomes, and we voted on those actually. So mortality and bleeding, again, because we give platelet transfusion to try to prevent or treat bleeding. Those were at a high level the most important outcomes. So I should mention that we used a paradigm called restrictive versus liberal, which is maybe familiar to many listeners who are familiar with red blood cell transfusion trials, where there's different hemoglobin thresholds for red blood cell transfusion that have been investigated in trials. We actually applied that same concept to platelet transfusion. We identified studies that compared liberal platelet transfusion strategies, so that would be kind of greater amounts of platelets transfused in general, to restrictive or fewer amounts of platelets transfused with the strategy in general, and tried to see, okay, if we randomize patients in clinical trials to restrictive and liberal, how does that impact these important outcomes of mortality and bleeding? Is there any difference between giving greater doses or having different thresholds of platelet transfusion versus not for those most important outcomes? We've identified 21 randomized trials. We also included some observational studies when the randomized trial evidence was very low certainty. So we had kind of a structured approach for what evidence we included and evaluated. Our primary PICO question, or population intervention comparison and outcome, was essentially what is the impact of a restrictive versus a liberal platelet transfusion strategy among patients who might be considered in need of platelet transfusion on those most important outcomes, mortality and bleeding. When we put the evidence together, which was a lot of work, you can compile the evidence as a part of a systematic review and basically do something called a meta-analysis, where you pool the evidence together. We did that among the 21 randomized trials as our initial analysis, and we found no important difference between restrictive and liberal platelet transfusion strategies for the outcomes of mortality and bleeding. We did other analyses too, but that was the general pattern of the evidence. So if there's no difference in important difference between in mortality and bleeding, restrictive versus liberal, then we actually made a restrictive recommendation because of the unequivocal benefits of restrictive strategies of avoiding adverse events like acute transfusion reactions, maintaining adequate platelet supply for patients most likely to benefit. As we know, platelets have a short shelf life of 5 to 7 days, and maintaining adequate supply can be challenging at times. And lastly, cost savings, avoiding unnecessary healthcare expenditures. So that was sort of the thinking that we applied to when we evaluated the evidence.
Wow. Well, congratulations to the whole expert panel. That's not easy to collaborate globally and come to consensus. How long did the process take you?
Well, I would say I probably worked on this for 2 years.
Wow.
Yeah.
From
Wow.
start to finish, and some others involved in the review even longer than that, actually, on the ICTMG side. So it really was a lot of work, definitely the most work I've done for an individual project. going forward. But it was, you learn a lot along the way, and I feel very fortunate to have had a phenomenal group of
Yeah.
people to work with. That really made it a lot of fun.
Wow. Well, thank you for that hard work because you're advancing clinical practice. So let's talk about significant changes. Were there significant changes in the guidelines and recommendations?
Yeah, there will be probably what seem like some substantial changes compared to the prior AABB guidelines and ICTMG guidelines to some degree as well. So overall, we made 11 total recommendations. As I mentioned, we evaluated the evidence across many different patient populations to look for a common effect of restrictive versus liberal. And the reason we compiled different patient populations together in our analysis is that the relative impact of clinical interventions tends to be constant across patient populations in evidence-based medicine. And this is a concept that may seem a little challenging, but it's overwhelmingly the case in evidence-based medicine. About 9 times out of 10, if you look at multiple reviews on this topic, relative effects of interventions tend to be constant. What patients care about are the absolute effects, which means, what's the likelihood that this bad outcome is going to happen to me? So
Yes.
mortality, for example.
Mhm.
And the absolute effects are often expressed as a risk in events per thousand. So you could say, okay, the risk is, if it's a 10% risk, absolute, you say 100 times out of 1,000, this event would happen to you.
Mhm.
That's partly how we sort of think about the decision making. And then we identified what we call minimal important differences. So what's the smallest size of the impact of effect that patients would consider important? So we defined that for our main outcomes, mortality, and a couple of different types of bleeding. Depending on what the overall absolute effect estimate was, that helped us determine whether there was an important difference between restrictive versus liberal for those most important outcomes. So just a little couple other comments on our methods of how we did things. So again, we did that across all populations. We weren't 100% sure that the relative effects would be constant. So we broke it down and did analyses in particular areas to support recommendations. And part of the reason we did that was because if you look at the trials, the definitions of restrictive and liberal varied between trials. So sometimes the definition of a restrictive strategy was no platelets at all. Actually, that
Mhm.
was fairly common.
Hmm.
Sometimes it was a platelet count threshold of 10,000, sometimes higher than that. The liberal definitions also varied quite a bit. Some in the hematology oncology population would be 10,000 or 20,000 platelet count threshold. And then some would be much higher, like in neurosurgery, intracranial hemorrhage. Even to get randomized into that particular study, the platelet counts of those patients needed to be 100,000. It's called the patch trial. So we knew that we couldn't just make a recommendation restrictive and good luck. We needed to say, we recommend this restrictive strategy, and the specific practical recommendation is as follows for those 11 settings. It could be recommendation for a platelet count threshold of less than 10,000 in many hematology oncology patients, but it varied a little bit. So 4 of our recommendations were strong recommendations based on high to moderate certainty evidence. And then 7 of our recommendations were conditional recommendations based on low to very low certainty evidence for those most important outcomes. And a strong recommendation is, the vast majority of patients would want this, 90+%. Conditional is 50 to 90%, roughly, patients would want this. It's often a good idea to have a conversation with the individual patient, if feasible, to talk about their values and preferences and make sure that, you're in line with those. So going back to your question about what are the significant changes,
Yeah.
there are probably several that will seem like significant changes compared to the prior AABB guideline. I think I can highlight a few examples here. So some recommendations were new. So for example, we made a recommendation for a restrictive transfusion strategy in preterm neonates without major bleeding. The platelet count threshold that we thought was practical as a restrictive recommendation was less than 25,000 per microliter. And a lot of that was based on the sort of largest trial called the Planet 2 trial as the basis for that specific recommendation. Interestingly, that trial showed evidence of harm with liberal platelet transfusion strategies, which, up front is not something you might expect. Lumbar puncture is another area where I think this is a good topic for us to discuss. The prior AABB guideline 10 years ago, there was a platelet count threshold recommendation less than 50,000 based on very low certainty evidence. For this update, we took a little bit of a different approach. We said, okay, well, what outcome do we care about that we want to prevent in patients undergoing lumbar puncture? And that's a spinal hematoma. We don't want hematoma forming in the spinal area because that can have bad consequences, paralysis, and so forth. We said, well, how common is that among patients with very low platelet counts? And based on our understanding of the literature, we said, well, we might hypothesize that actually the spinal hematoma rate is very low, even among patients with low platelet counts. Instead of looking at randomized trials, because they don't really exist in lumbar puncture, comparing restrictive versus liberal transfusion strategies, we hypothesized that the spinal hematoma rate was near zero. And we took observational studies that reported spinal hematoma rates among patients undergoing lumbar puncture, and we pooled those together and said, what's our best estimate of what the risk of spinal hematoma is for an individual patient? For patients with platelet counts less than 50,000 just prior to the procedure, the risk estimate was 0.8 events per 1,000. So very low. And then we said, well, what about even patients with less than 20,000 for their platelet count? And that risk estimate was zero because among those 4 studies that we included, and we identified and included and analyzed, there were no spinal hematomas that occurred. So we felt like we could probably move to a more restrictive recommendation threshold from the prior guideline recommendation of 50,000. And we thought a practical recommendation was for 20,000 as a threshold, even though, as I mentioned, the event rate was zero.
Right.
Before then. We realized that moving from 50 to 20 in itself might seem like a big jump for people, but we still thought that, this was sort of a practical happy medium to implement where we could avoid a lot of unnecessary platelet transfusions. I know in my practice, we have cases where people are trying to get a platelet count up above 50,000. If the patient is refractory to platelet transfusion, we feel like we're spinning our wheels a bit, perhaps not providing any benefit for the most important outcome, which is spinal hematoma.
Wow, it sounds reasonable. Yeah. Mm-hmm. Well researched.
Yeah, and I think, because spinal hematoma is an outcome that people are very concerned about, we recognize this is something that we're going to have to be discussing and making sure that we talk to stakeholders at our institution, and we think about implementation science research. We're moving in that direction. This is one recommendation that I think is of particular interest.
Yeah.
A couple of other recommendations. So among patients with hypoproliferative thrombocytopenia, meaning their bone marrow is not making a lot of platelets or many platelets at all, for patients that are at higher risks, which would be those actively receiving chemotherapy or undergoing allogeneic stem cell transplant, we made a recommendation that will seem familiar, a platelet count threshold of less than 10,000. But for patients undergoing autologous stem cell transplant, which are quite common, we actually made a recommendation for what's called a no prophylaxis strategy, meaning even if the platelet count drops below 10,000, we would not administer a platelet transfusion in the absence of bleeding. And the reason for that is we evaluated the evidence, looking at the most important outcomes. There was some inconsistency from one trial in particular for grade 2 bleeding, not grade 3 or 4 bleeding, which is, arguably some would say the most important. So that's part of the reason why this is a conditional recommendation as a no prophylaxis strategy based on very low certainty evidence for grade 2 through 4 bleeding. In particular, we think this will potentially avoid some unnecessary transfusions, perhaps improve quality of life as well for patients who, may routinely get a lot of platelet transfusions that potentially could be avoided. Another recommendation that might be of interest to mention, I won't hit all of the recommendations, but I'll just mention one more. We made a conditional recommendation in patients with spontaneous or traumatic non-operative intracranial hemorrhage with platelet counts greater than 100,000, including patients taking antiplatelet agents inhibiting platelets. We made a recommendation for no platelet transfusion in that setting as the restrictive strategy, in part because the direct evidence we had in the spontaneous intracranial hemorrhage group is from the patch trial, which, if anything, suggested the possibility of harm. There's some questions about that trial related to balance between groups. Were they similar risks, which I think are important questions to think about. But also remember, first of all, between the two study arms, there were no differences in rates of hematoma expansion. I think that's an important point. If the patch trial showed evidence of harm with liberal platelet transfusion strategy, for us to make a recommendation of liberal, we would actually have to move from evidence of benefit to restrictive, past no difference, all the way to benefit with liberal. So that would be a bit of a jump as well. And we also considered the concept of indirect evidence. So I mentioned earlier that relative effects of interventions tend to be constant across patient populations. Because we saw a pattern among the 21 randomized trials showing no clear benefit of liberal, that gives us probably some additional confidence in making recommendations in settings where we don't maybe have as much evidence in particular. One last recommendation I'll mention is among adult patients with consumptive thrombocytopenia due to critical illness. We, sometimes we'll use a platelet count threshold of 20,000, but these patients can often be refractory to platelet transfusion. So we actually used adjusted observational evidence here and made a recommendation for restrictive strategy and a practical threshold of less than 10,000. That's a conditional recommendation based on very low certainty evidence. I think that would be another one that might be of interest to mention.
These are all very interesting, and I can tell you got so much joy out of doing this research. I'm really looking forward to reading all 11. How do you think that the clinicians will respond to this? Do you think you'll have a lot of negative or a lot of positive?
Yeah, I think that's a really important question, right? So putting together guidelines like this is a great deal of work, but the work is not done, right? The work of implementation, you could argue, is just as important. If we don't implement them, what's the point of making the guidelines? So, we've had discussions, many of us at our local institutions and amongst other colleagues to try to get feedback, which has been very helpful. It's interesting. I think it depends on the person, sometimes depends on the country in which they practice. And, there's sort of different, probably psychology of practice among different places. I think we've gotten a lot of support and positive feedback. Then there have been some that have said, oh, we're moving to 20,000 for lumbar puncture. Let's talk a little bit more about that. It's very helpful to hear that feedback so that we can say, okay, let's sit down. So I'll set up meetings where we can go through the evidence, our rationale for making the recommendations that we did, and thinking through it. And when we do that, everyone that I've discussed with thus far has become more and more comfortable with the recommendations. I think we expect some controversy because there are substantial practice changes from this. We certainly welcome dialogue and discussion and thinking about how to approach this, and especially moving toward implementation. We had a pretty large group working on this. We thought pretty hard about how to make these recommendations, and we hope that with implementation, we can improve patient outcomes and also avoid some unnecessary transfusions along the way and maintain supply for those most likely to need it.
Dr. Metcalf, can you articulate for us really what's the harm in transfusing platelets in a patient that's not bleeding, but they have a low platelet count just as a preventative measure? Doesn't more platelets help?
I think one important thing to keep in mind is that any blood transfusion comes with a risk of an adverse event. Interestingly, platelets in particular are the component with the highest risk of adverse events. So that's another thing that I think is important to keep in mind. The true estimate of what that risk is may depend on the patient population, their risk factors. We do about 100 transfusions per day at my institution. You can imagine that probably about 3% of transfusions come with some sort of an adverse event. Some of those are milder, like mild allergic transfusion reactions, so hives on the skin. And then, some can be severe also, and potentially life-threatening. So it isn't simply if we transfuse a platelet that's unnecessary, there's no possibility of harm, because unequivocally there is a possibility of harm. So we really want to make sure that each of those decisions balance the benefits and potential harms as much as possible in a way that hopefully improves patient outcomes and is in line with the individual patient's values and preferences.
I'm glad to hear that you've incorporated thoughts about patient response to this, patient outcomes, because really that's the most important thing in patient blood management, right? The patient. And that's why patients should care about this, not just providers. What kind of impact do you think that you'll be seeing from these new guidelines, particularly with the patients?
Yeah, I mean, I think in terms of impact that will be easily measurable, if we have successful implementations, I would expect a reduction in the number of platelet transfusions and associated costs. Metrics related to supply might improve. Adverse events, I expect to go down. One thing to keep in mind is that transfusion reactions at most institutions are reported passively. And so we rely on clinicians to tell us when a suspected transfusion reaction may be occurring, and that
Right.
is well known to be underreported.
Mm-hmm.
So directly measuring the true adverse event rate can present some challenges. But nevertheless, we can make estimates, right? We will see
Right.
the number of transfusion reactions, number one, that do get reported. And then also based on the active surveillance studies in the literature, you can make estimates of likely proportion or number of adverse events avoided. So I think those would be some options for outcomes to look at with a successful implementation.
I know I'm looking forward to, I think this year is going to be full of talks about this, responses to it, successes.
What do hospital organizations have to do to make sure that these are implemented?
That's a great question. And we are, chatting with some implementation scientists. But Sarah, we're working on locally, as you know, is thinking about, okay, who do we need to speak with, right? Stakeholders. So we've already met with several stakeholder groups likely to be impacted. We'll set up meetings, discuss the evidence and the new recommendations. In terms of our order design and our electronic health record, we have, what you might call intelligent ordering, quote unquote, where we require the ordering individual to tell us why they're transfusing the patient. And if for example, platelet count is not in line with what the indication selected was, we will have a clinical decision support or a pop-up best practice advisory questioning whether that transfusion is actually necessary. So we're redesigning those indications to try to be consistent with the new guidelines, but also, efficient and minimize clutter, make the workflow convenient for clinicians. And then we use audit and feedback as well. So we'll audit practices relative to guideline adherence and use data visualization to provide feedback to those clinicians. Those are several of the things that I think one could work on. Another thing from an implementation science perspective to think about could be, among those recommendations, which one or two even would you want to prioritize at your institution to focus on if they're expected to be highest impact, for example, most controversial. That can be another important area to focus on. One thing I also want to mention, I don't want to forget to mention, is we made a good practice statement. So a lot of times when you make clinical practice guidelines, we will add a good practice statement to the paper, which essentially says, look at the patient, right? We are providing recommendations based on the available evidence. It's a possibility that there may be some other things going on with your patient that may not perfectly fit, right? This patient population. So if your patient has a extensive history of bleeding, for example, recent bleeding, but there's no bleeding currently, or no worsening, let's say, of a prior intracranial hemorrhage, you want to think about if patients on anticoagulants. There are many different considerations beyond simply the platelet count when considering whether to transfuse an individual patients. That's kind of what our good practice statement is. Another thing to mention is that regardless of liberal or restrictive, in many populations, the rates of bleeding still remain not low, somewhat high rates of bleeding. So I think that's an important point when we think about the psychology of the decision to transfuse, because if the bleeding rates remain, higher than we would like, we want to do something about it. Clinicians want to do something about it. But I think partly what we're showing here, the guidelines, is that that doesn't mean we should give a platelet transfusion if it's unlikely to provide a benefit and reduce in an important way the rates of bleeding in those patients. So I think that's another tricky thing where people do want to do something to help the patient, but we may need to consider alternative approaches from platelet transfusion.
Very good. So in summing everything up, what is your overall message and takeaway that you would like the listeners to carry with them at the end of our discussion today?
We hope that blood transfusion can, when it's used appropriately, can improve patient outcomes. We try to work together as a large expert group and patient partners to come up with evidence-based recommendations to really help optimize how those decisions are made to improve patient outcomes as much as possible while minimizing the harms that accompany platelet transfusion. We hope, if there are patients listening to this, that they feel empowered to have discussions with their clinician providers, if they may be considered for a transfusion, about the risks and benefits, and think about their values and preferences. And, even things like time away from families, right? Coming in for a lot of platelet
Yeah,
transfusions over time. If some of those visits could be avoided and you can get
yeah.
to spend time with your family or doing other activities you like, I think
Mhm.
those are really important discussions to have with clinicians. We hope that with implementation over time that we see impact from all this work, because we spent a lot of time on it.
Well, the name of the article is Platelet Transfusion, the 2025 AABB and ICTMG Clinical Practice Guidelines. We will provide a link to that article in our description so that you can easily find it and reference it. And thank you so much, Dr. Metcalf, for taking the
Yeah, this has
time.
been great.
Thank you both so much for having me. Really appreciate it.